Good. Okay, so we'll browse through this quickly. So I'm going to talk about cervical disc arthroplasty quickly. No financial disclosures. There's a reason I'm going to talk about one of the implants more because after trying all of these, let's not go through why we are doing this. We already have this case. We'll look at the options, right? So this patient presented with less of neck pain, but more of radiculopathy, arm pain, right? So forget about so we want to try conservative management, which has already been tried. Options. Conservative care, of course. From anatomy, I think for this case, a posterior cervical endoscopic, MED, endoscopic, both is a very reasonable option. The only problem is it's already 6 months out. So the disc is a little hardened when you do it from the back. So let's talk about ACDF, which is a time tested. Everybody knows how to do it. I'm not going to go into the details of how we do this, but we'll talk about why we do this, right? So ACDF, I think, is the gold standard. It has been time tested, more than 50 years in practice. Most spine surgeons are familiar with it. However, the fusion changes the biomechanics of the cervical spine and their potential long-term consequences. You know, I didn't really believe in this till I started talking to a lot of people. I tried my first arthroplasty in 2012. So I've been through the tradition of, you know, all the transition of different implants. So why I think if you don't own it now, this is the future. This is what I believe, because I've followed my own patients for at least about 3 years now. When I was, so the outcomes are very similar to what I found in literature also. All these are our own cases, standard ACDF, 2 levels. This is the initial Medtronic disc. This is what I do now. This is a Mobi-C, which was recently bought over. I think this is, when I offer somebody or when I'm planning to do something, I always look at what the bailout is going to be. You always start with single level, and then you go to 2 levels or 3 levels. 2 level has been approved now. The bailout for this disc is very significant. This is a corpectomy. So it is very tough to remove these. Before I decided to use this in 2016, I wanted to feel how difficult it is to move it. And this is a piece of cake. So um, so this is an outpatient procedure. We do this, send the patient home 2-3 hours later, done in a general anesthesia, just like a standard ACDF. I really believe, and the literature also shows, for 2 levels, patients have less interscapular pain also. We don't do a lot of distraction. You're not plating them. You're not. So it's designed to maintain the cervical lordosis, the spinal biomechanics, and has definite clinical advantages. Let's look at this slide. So these are the lessons learned over time. This is a patient which had an ACDF, a standard autograft at that time. And the adjacent level disease, adjacent degeneration is a real, we tend to ignore this, whatever country we are living in. But if you follow these patients long term, I can bet that nobody amongst us is following these patients for years, right? We don't see them more than a year. And in this case, when I was in practice in US, I realized that the orthopedic guys are more, I think they follow them up longer, up to 2 years, some of them. So 1970s, you can look at the adjacent, had a C5-6 autofusion, very nicely fused, but there's increased radiographic adjacent and then 1980s, you can see how the upper level has been involved. So in contrast, the clinical results of cervical disc replacements are very obvious, are designed to maintain the physiological motion and minimize the downsides of fusion. So less radiographic adjacent level disease, fewer operations, 4 times less, better disability improvement, and this is for the 2-level study which came out, and the maintenance of motion up to 7 years as compared to ACDF. Return to work 3 weeks earlier, 2-level. Single level, this was my first 2-level. This was done in October of 2016. This gentleman eventually became the rep for the company. So he was so happy, he left Medtronic and got employed with this company, Mobi-C, which had, so I'm still in touch with, so at 5 years, he's basically pain-free. And this is, 2 levels after that. So history, all these models have been out there. You know, it's been going on since 1990s. They've been talking about artificial disc. ProDisc, Medtronic, Brian, Depew, all of them. This is the initial Mobi-C. So any disc, artificial disc, which has a keel, where you have to drill a keel into the inferior aspect or the upper, that will have consequences if you have to remove them. So why I like this one, this was the first 2-level artificial approved in 1 and 2 level. Multiple implants been done. It's not a, so ideal arthroplasty should have a completely titanium. So this is cobalt, has a layer of titanium also. So Mobi-C study is the largest concurrent cervical disc clinical trial ever conducted. So it was done over 24 centers, almost 60 operating surgeons, almost 600 patients. But let's look at just the quick outcomes. So adjacent segment disease, adjacent segment degeneration at 5 years. Blue is ACDF, green is arthroplasty. Let's follow them up at 2 years, 48 months, 12, 24, 48 months, and at 60 months. So clear difference with a statistically significant difference between an arthroplasty. But for a single level, I think secondary surgeries that patients who required through those 5 years was significantly less for the arthroplasty as compared to this. So subsequently, over 60 months follow-up, rate of motion through 5 years, you can see the difference. NDI, this is a disability index which is given to all these patients, and then they're followed up. And this was published, which showed the 2-level demonstrates statistically difference in this disability versus the fusion over time, over 60 months. So this is a good chart, a good slide to look into. 1-level study. So I would say 1 level is as good as ACDF, right? If not superior, about the same. But a 2-level study, there's a significant difference in the return to work, as well as difference in the pain threshold. So 1 level, 2 level again. And you can see that Mobi-C patients, the arthroplasty. So 65% versus 73% fusion, very similar, not statistically significant. So, but we also know that the efficacy of fusion, it decreases as we increase the number of levels. So routinely, before coming to here, every time you do a case, you have to worry about how much it's the patient, how much are we going to pay for the implant, right? This is the real thing. So standard 3-level fusions is a very routine in the Western world. But I think we are doing less and less fusions over here, but arthroplasty, so no non-inferiority to fusion, definitely superior to fusion at 2 levels. You can see the 1-level study, very green is again the arthroplasty, and blue is the some of the literature available. Questions? Salman, I hope this was not too